beds that were hard beds. Now we have soft beds that are come, but that is not adequate. So we have two kinds of mattresses. Which are the two kinds of mattresses? Underlay and overlay. When I say overlay, what does it mean? I take a mattress, put it on the existing bed, on the existing mattress. That's overlay. When I say underlay, it means I am removing my mattress and putting this big mattress inside. Now, what are these mattresses actually? What are they? How are they preventing a pressure ulcer, Ashok? How are they preventing it? How are they preventing it? Guys, how is it prevented? Have you slept on it? Huh? So you should sleep on it. You realize it. If you sleep on it, you realize what happens. So what happens is, it's got cells of air. It's got cells of air. Cells of air is in the mattress. It alternates. तो ये पहला फूकता है, ये और ये फूकेगा, बीच में तो नहीं फूकेगा, फिर ये और ये फूकेगा, बीच में नहीं फूकेगा. So the pressure that is exerted in the engine movement keeps on changing. So first the pressure is at these 2 points, then the pressure is at these 2 points, then the pressure is at these 2 points. You are understanding? The pressure keeps on changing. That is what the air mattress is all about, right? That is why it is uncomfortable. That is why it is very uncomfortable for you because you are not doing it. The mattress is doing it. When you are sleeping, you are changing depending on pressure. You are changing yourself. आपका body change हो रहा है. Either क्या हो रहा है? The mattress is changing here, right? So it's very uncomfortable to sleep on. Very uncomfortable. I like sleeping on. And I initially when I slept, I felt अरे अच्छा है. Then after some time I was not getting sleep only. Otherwise sleep because of the fact that that mattress was upsetting my entire thing, my body. If you sleep on it, you realize it. It is very difficult. Okay. So you have to have an appropriate use. So some people sometimes they say yes, use a donut. एक टायर होता है, टायर. वो टायर पे पेशेंट को ऐसे बिठा देंगे. So that the sacral ulcers don't form. It is not supposed to be used. It is not supposed to be used. So use of donut is not something. There is something called donut. You'll see it in hospitals which don't have intensive care doctors who have not been trained in intensive care. They use all these things. You're not supposed to use that. Those devices are more to increase pressure ulcers. Okay. Now, as a bedside doctor and a nurse, what is important for you to understand if you have an air mattress? How to deflate it? Because now that there is an air mattress, whatever CPR is going to happen, it is going to be ineffective. Whatever CPR is going to happen is going to be ineffective. So, as a bedside physician, we need to know how to deflate the mattress. Now, so do you all know how to deflate it? Ashok? Shalaka? Alia? So you should know that. It's very essential. It is very essential that all of us know how to deflate the mattress. It's very essential because in the event that the patient is arrested, okay, your CPR is not going to be effective unless you deflate the mattress and have a hard board. It has to be a hard board. Your spine has to be on a hard board. So the bed is hard board. If you don't deflate the mattress, your CPR is not, how much of a time you do CPR, it is not going to be effective. So whenever you are going for a CPR call, the air mattress needs to be deflated. Unless you know how to deflate it, you will not be able to deflate it. So today when you go back to your ICU, please understand how to deflate the mattress. It's very essential. It is very essential. Okay? Because it takes time to deflate it. And that crucial amount of time is the time between brain death and brain not working and good outcomes. Okay? Yeah.
These are the pressure sore areas. This is the supine position.
So I was very surprised when I actually saw the patient yesterday, our patient of head injury and trauma. Okay? Why did you all keep the cervical column? When a patient is on the ventilator, you don't need a cervical column. Are you understand what I'm saying? A cervical column is a hard column. A cervical column is a hard column. Right? When is a cervical column given? When the patient is going to be mobile. Your cervical column is going to come in place when your patient is going to be mobile. When the patient is going to be mobile. This patient is immobile. We are putting the collar for what? Not to heal their spine. We are putting the collar so that the spine doesn't get mobile. Right? So if the patient is on the bed and he's just sitting on the bed, all you require is sandbags. By putting a collar, you are actually putting this patient to a risk of pressure ulcer. Because what happens with a hard collar? The hard collar will hit on the mandible, will hit under the ears, and it will hit under the oxygen. cannot be placed for a long time. So whoever has worked with that patient, please take that collar, put it on yourself and try to sleep. I'm telling you, unless you do this, you will not understand what I'm telling you. You will not understand. I came next year and said, it will become this home. You understand what I'm saying? Simple things. A spine board. You cannot lie on a spine board. It is impossible. Have you tried lying on a spine board? Sister, you should get the spine board or नीचे ERC पर मंगाओ spine board. Spine board. There's a spine board. Or patients who are on rotary accidents, they are placed in a spine board. A spine board is a large which is for place to hold. Place to hold. If you lie on the spine board, you will realize that I can't lie for more than 15 minutes also. It is so hard, the spine board. Okay, and when you have a spine board also, they don't put this collar. They put bilateral bags and they close it from the top. Sandbags, and they close from the top, or they put boxes behind and they close from the top. That is because this collar is going to be very, very dangerous. You understand? So if you put a collar, the next step is when to remove the collar. If you put a spine board, when to remove the spine board. You can't just put the collar and forget about it. That patient will get irritable, that patient will have a sore over here, you will never realize it. You will never realize it. You understand? So we don't require, you never should put a hard collar. First of all, never put a hard collar in a patient who is mechanically ventilated and who is sedated. Nahi dalna hai. You are not supposed to do that. Okay? A patient will not even be able to complain. You understand? If you put a cervical collar, it is important for you to discuss with the orthopedic surgeon. Should I really continue this or not? Or the spine surgeon, should I really continue this or not? Take his approval. Because tomorrow if the patient gets a bed sore, the quality of the ICU is supposed to be very poor, not the quality of the surgeon. Are you understanding? So we know that the incidence of dislocations are much more higher in the use of a cervical collar, because by inserting and removal, there is going to be changes. Are you understanding? That is why in a patient who is ventilated, we don't want to use cervical collars. We rather sedate them well. Are you understanding? So that is why even if you want to use a collar, try to use a collar that has less pressure source, not that kind of collar that you put. You should have put a Philadelphia collar. A Philadelphia collar is the one that comes big like this. That has got much more silicone as compared to the collar that you put yesterday. I was surprised to see that collar. I am seeing that after the Sion hospital. You can't have that white collars. Are you understanding? Philadelphia collars is what we use. You've seen a Philadelphia collar? It's a brown collar. It's a brown collar that goes full like this, which is soft. Because our entire thing is not to fix the spine. Our entire thing is to prevent it from movement. So if it just holds here and here, that is enough for me.
So these are the patient ulcer high risk group, pre-op, intra-op and post-op group, pediatric intensive care unit as well as adult, bedridden patients, especially those with spinal cord injuries, those who are hemodynamically unstable, elderly and the very young are primarily at risk of developing pressure.
So this becomes very important for us in intensive care. So if you have a patient who is on NORAD, you already have vasoconstricted half the circulation. In fact, the whole circulation is vasoconstricted now. So the existing flow to the vessel is already on the lower side. And on top of it, when we actually put the patient in one position for a long period of time, the pressure goes so high that they develop redness, they develop ulcers, and they develop pressure sores.
These are the prevention strategies. So alpha bed, cabinet spray, iodine patch, iodine pad, gel pad, moisturizer, positioning, second early and
So do
early.
you all know these things? What are these things? The alphabet is a bit that we use. The overlay matters that we have. The cavilar spray is for what? Wait a second. What is cavilar spray for? What is the cavilar spray for? What is the cavilar spray for? So have you used the cavilar spray? So have you used it on yourself? How did you find it? Sorry? Yeah, so it creates a film. It creates a film. So even if there is moisture, it doesn't get into the skin. You understand? So it doesn't dry out. It creates a film. That's what a cavilar spray is about. So if you have a person who's soiling the bed again and again, who's obese patient with groins are full of moisture, you apply the cavilar spray, it will remain on top and prevent this water from seeping inside the skin and causing moisture related problems which we know from practice. Are you understanding? The cavilar spray. You know what
You can use that for 12 hours.
Yeah.
Not second, 12 hours.
That can be used once in 12 hours. So even if the patient soils the bed, at least it will not affect it. Cavilar spray. Then these are only supports. Nothing can replace this. These are only supports. So when you say aluminum patch, it's the patch that you apply. Heel pad, gel pad, moisturizers, second hourly, and early mobilization. Yeah. Okay. Right. So what is your SOP for the your later? So what we are planning to do is we this is a never event. We should not have a single pressure stroke. Okay. So we want to audit. So we want to audit our pressure, our mobilization strategy. Okay. If these are constants of alphabet, capitals, we will be finding out a certain we will be finding out a group of individuals which are going to be liable for a pressure stroke, first of all. That will be our inclusion criteria. Those people who are going to have a pressure stroke, probable, highly vulnerable, less than 16, that is for less than 16, all of them are highly vulnerable in intensive care. Okay, so those are those patients which will be taken up in this particular audit. Okay, not that angioplasty patient that comes in and is the reason for that patient. The second thing we will do is we will then have one of the nurses, one of the doctors in charge of this, where they will see whether the patient is being mobilized every second hour, because the standard is every second hour. So that nurse will actually figure out whether every second hour this mobilization is taking place or not. Okay, that nurse or that doctor for that particular. You will have a chart saying mobilize, not mobilize, mobilize, NM, you put the entire chart. He or she, the nurse or the doctor. Right? Position changes. So 2 hour days will change, not change, it should not change. That will NM will be there. So there will be doctors and nurses in each shift that are going to be deputed on that to understand whether this is taking place. Say it is not taking place. So we have to figure out that it is not taking place. It will definitely not be taking place. Okay. So we will figure out that this is not taking place. Once that is not taking place, we will then do a certain alteration in a device. And then it again will start. This is going to be our plan. We'll do a change and we'll put a clock beside the patient with left lateral, right lateral, left lateral, written on that clock or something. So you know that at this position this patient has to be at this front of you. You understand? So we'll put that in place to understand whether this works or not. So this will be our clinical audit. The clock will be probably our intervention, and then we will again assess ourselves. Clear on this? So who will be chosen for? We will be putting 4 of the IDCC nurses on this. Before IDCC nurses on it, and we will have other doctors on this. Let's go.
Smita.
You are putting them. So we will anyway start the audit. We make the Excel sheet. Today we make the Excel sheet along. Smita is not there, so Smita let Sachin take it. Sachin is joining us by this week, next week. Next week Sachin is joining into the intensive care. Smita you will come. So Smita and Sachin will come. और तो स्मिता और नीता चंद्रिमा के